Russian doctors must know stars of
I've
interventional
done
cardiology.
case in Moscow.
Yeah?
Yeah.
I've
I've done a total.
Okay.
I've done a total occlusion in Moscow, main stem, total occlusion main stem, at the age of 42, and I published with the fellow from Russian.
Okay.
Yeah, I don't know which journal. And then when I had opened the main stem, circumflex, I asked, give me a stent, and they said bare metal stent. I said, no, I want to have a drug-eluting. Oh, it's too expensive. So I called the auditorium. I said, is there somebody from Cordis with a cipher there? He said, yes. I said, come to the lab and give us two. Okay, what do you want to know?
Dr. Patrick Serruys, interventional cardiologist in University of Galway, Ireland. He was the first chair of interventional cardiology created by the Royal Netherlands Academy of Arts and Sciences. Professor of cardiology in the National Heart and Lung Institute of Imperial College in London. TCT Career Achievement Award in 1996. Career Achievement Award from the American College of Cardiology. Gold Medal of the European Society of the Cardiology. In 1977, along with Andreas Gruentzig, he started to work on interventional cardiology. In 1987, he introduced the stent technique in the Netherlands. He was pioneer in introduction of bare metal stent. In 2006, he introduced biodegradable stent. Professor Serruys spent most of his time in research activities. As he said, it is important to be curious. Don't look at the past. Try to guess the future.
How did the history of cardiology, interventional cardiology, started for you?
For me, it's pretty simple. I went to the third course of Andreas Gruentzig, which was 1980. That was the third one. After that, he went to United States. And then we were there for 3 days. I purchased 5 balloons. Each balloon was $5,000. And the balloon was 4.2.
Oh, okay.
There was not yet the 3.7 and the 3.5. And then there was a pump and CO2 to push the contrast in the balloon. Now we do with the end, but it was a complex CO2 for the pressure in the balloon. And then I bring back and I put that on an hinge of a door because I didn't want to have air at the top of the syringe because otherwise the CO2 was pushing the air and not pushing the contrast. And then it took me 3 months to find one patient who had the vessel diameter of 4 millimeters because there was only the 4.2 balloon. And at that time, the guiding catheter was 9.7 French. When the balloon was in the catheter, you could not make an angiography. You have to dilute the contrast and push very hard to see a little bit the coronary artery. And then what was also amazing is that we were not looking at the angiography, we were looking at the pressure. So in the balloon of Gruentzig, you could measure the pressure distally. There was a very short wire of 2 centimeters. There was no wire. It was just a small piece of metal at the tip of the balloon. And then we were looking at the pressure. There was 2 pressure. And when you cross the lesion, then there was the gradient. Then you inflate the balloon and you deflate. And if the pressure was coming back, it was okay. But if the pressure was not coming back, we were already calling the surgeon.
Okay.
And the success rate was 70-80%. So every week we were doing 1 case a day at a certain time, always after 5 o'clock, because the surgeon has to be standby.
Yep.
And on 10 patients, we were sending 2 to surgery. And it's only when I get the long wire of John Simpson in 1982 that we were able to do 100 patients without sending a patient to surgery, because we have the long wire. So when it was ugly and dissected, we were using a big balloon. we were dissecting even more, so that there was a flow was maintained. And when we discovered that the bad result, we should use a bigger balloon to completely dissect, then we get 100 Ks consecutive without sending the surgeon. That was the end of the difficult time. The rest is history.
Do you remember your first patient that you stented?
The first patient that I stented very well, it is a Chinese lady, which was living in the Netherlands, and I put a wall stent, yeah, and that was okay. We follow for more than 14 years. At one of the last course on stenting in Rotterdam, I interview. I can show you the interview, and it's funny because I explained everything, that she was the first receiving a stent, etc. And then she asked me, "Am I a guinea pig?" I said, "Yeah, you are a guinea pig." Yeah, but the result was good. After that, it was more complicated. But that lady, the first with the wall stent, was okay. And it's amazing because I did angioscopy in the first patient, and I feel guilty because when I saw in angioscopy the metal in the nice pink coronary artery, the soft tissue, and then the metal, I said, "What I've done here?" But that was 1986, September 1986. Yeah.
When did you, for the first time, felt that you are not dependent on surgeons? When you became confident with your PCI?
Yeah, it came progressively. I think that what happens is, I told you, we were always the procedure at 5 o'clock because the surgeon has to be standby. But sometimes we were calling at 5 o'clock, and the nurse was saying, "Oh, all the surgeons are gone." So we have to cancel the PCI, PTCA, like we said at that time. So at some point, one morning, I said, "We do this morning. We don't wait 5 o'clock. I cannot work like that."
Which year?
Which year? I think it was at the end of 81, 82.
Okay.
81, 82, I said one morning, and then when they heard that we had a complication, oh my God, they were cross. But the decision was done. Then we continued to do at 8 o'clock in the morning and not at 5 o'clock in the evening.
So when we got our intravascular imaging, it was a big step forward in the interventional cardiology. What do you see will be the next similar step in our specialty?
I think that what is going to be the big change, and tomorrow I'm going to talk about that, is that the cineangiography, the conventional cineangiography with fluoroscopy, is going to be replaced by the multi-slide CT scan. That's the big step.
For diagnostic procedures?
For diagnostic, yeah. You will not long anymore do a diagnostic with a cineangiography. It will disappear. Already today, we have done 101 patients with three-vessel disease and main stem going to surgery directly without cineangiography. I'm going to show that tomorrow. Yeah. So I think that the multi-slide CT scan is getting so good that it will be the diagnostic tool number one. And the reimbursement in the United States has increased from $224 this year of last year to $900. So it's really becoming a diagnostic tool, and it's good for the planning of PCI, the planning for surgery without cineangiography. When you have a multi-slide CT scan the day before going to the interventional suite, you know where is the calcium, you know if there is a total occlusion, you know what kind of bifurcation you have. So you make your plan and you go immediately in the correct projection, LRO 10 degrees, cranial 31, etc., because you know that you will insert the guiding catheter in the mainstem. You know in the other projection you will see exactly the trifurcation of the thing. So the planning is very, very important. To use the conventional cine fluoroscopy to make a diagnosis of coronary artery disease is not allowed. And we need time in the lab to do left appendage, circling of the mitral valve, TAVR, total occlusion, bifurcation. We need time. We cannot afford to do coronary angiography. The problem is that still today, radiology and cardiology are separate in many institutions, but they have to merge. You have to create cardiac radiologists, a mixtures, an hybrid. That's very good. That's what is necessary. Yeah. In type of device, what is going to happen is that we are going to blend the therapy. You will have metallic stent, drug coating balloon, bioresorbable, and so that's one important things in the next 5-10 years. And the second is that interventional cardiology has to work with the pharma, because now there are powerful drug coming in the future. You have silencing RNA for PCSK9, LPA, CRP, one subcutaneous injection, and for 6 months, your cholesterol is at 50 milligram. So people can enter in the circuit by acute phase, and then you start the secondary prevention, but we start also to do primary prevention based on genomic, and then identify the patient and treating this patient very early. Valentin Förster said that he's only interested between the patient from 20 to 45. After that, it's calcify, you need lithotripsy, cutting balloon, scoring balloon, and so. But the young patient has still soft plaque, who can regress, yeah? And the very last thing, I'll show that tomorrow, is gene editing. It's coming. There is now the first trial which is going to start on 40 patients with familial hypercholesterolemia. One injection and your PCSK9 disappear for the rest of your life. There's a loss of function. You eliminate one adenine cytosine, one adenine guanine, and then you have no more PCSK9 for the rest of your life. That's what we are going to see in the next 5 years, and it will change. I was at the American Heart Association. They asked me with Marty Leon and other people, 2 other people, to talk about the next century. Now, I cannot talk about the next century. I can only talk about 5-10 years. But I think that atherosclerosis could disappear. You know, during the Second World War, streptomycin came, even before penicillin, okay? Penicillin was discovered before, but streptomycin was the first antibiotics. Now, between 1945 and 2000, 1945 and 2000, the infectious disease has quite disappeared. Okay, of course, you have resistance to antibiotics and so. So I think that could happen. You could have a vaccination against atherosclerosis, and you can have gene editing. That's what is going to happen. Yeah?
The question is about, do you give your knowledge to the next generation? You train fellows, you train maybe researchers. Your knowledge that you accumulated over this great career that you have, do you pass it to your next generation?
Yeah, I have trained 300 people.
Cardiologists.
I have 99 PhD. I hope that I will do the 100 very soon. And I work with 19 cardiologists from China, Japan, Egypt, and India. And they do only research, but practical research. Yeah? They take 2 years of their practice because they are a little bit saturate. They are 35, 45, and they have a little bit burnout syndrome. They don't see what they are going to do for the next 20 years. And then they come to work with me for 2 years, and we talk about all these things because they have to look to the future. They should not look to the past. If they repeat the past all the time, it's not interesting. So you have to get, you can be an interventional cardiologist, but you have to look to gene editing. If you don't understand that, you will be lost. You will be a doctor of second class very, very quickly.